Hello.
Hello.
Hi, Mansi, is that you?
Yeah, that's right.
Where are you? I can't see you.
Yeah, you can't see me because my video is turned off.
Okay. So this is
So
fine, right?
did you manage to get his CV?
Yes, I got it.
You got it. So you don't need me to display it, right?
I don't know. Whatever you do, you want to display it, you display it.
No.
His name is Joseph Berger, na? Because you've written Joe Berger.
No, yeah, it is Joseph Berger is his complete name, but
Hmm.
he's known as Joe Berger, and it's
But
actually Berger.
Berger. Okay.
Yeah,
Okay. Joe Berger. Okay.
yeah.
Fine. Yeah. Yeah. I think I'm more nervous in introducing a person than he must be giving the talk.
He is. I mean, of course. I mean, given his stature, I'm pretty
Yeah.
sure he's used to.
And I think, this whole Zoom thing is a little scary.
Why?
I don't know. To be on the screen and all, I think.
Uh, if
You're a
that way.
pro.
Sorry,
You are a pro. I can see that.
it's not about me being pro. It's because I work in the IT industry. I understand that your data is being sold left, right, center. You post pictures on Facebook, on Instagram, or anywhere.
Oh, what is your background, Mansi?
I'm a doctor.
In means a medical doctor,
Yes.
and you have a background in IT. How is that?
Yeah, that is because I work in a healthcare IT firm.
Oh, okay. So you're mixing the best of two worlds, and such a rare field.
Yeah, it is. Yeah, it is a lot of fun to like sort of what do you say? Discover a lot of things.
So, is our data going away by being part of this Zoom and all things?
Which data?
Means any? It's pretty
No.
safe, no?
What is your definition of safe?
Yeah, I think I'm asking the wrong person because you
No,
say, "Sudhir,
it's not about
hello, hello, we lost you, Mansi. Hi, Ratnamali.
Hi,
Hi, how are you?
I'm good. How are you?
I'm good.
I think I have to remove my picture. Just a minute.
Uh, remove your picture as in, it's nice to see you.
Can
Yeah,
you hear me?
some background.
Hello.
Yeah, I can hear you, Mansi. Yeah, now you're clear. Otherwise, it was all very blurry.
Yeah,
Hello, can you hear me?
Yeah.
yeah.
So,
Yeah.
Mansi, my screen is not seen, no? So I can do anything on my screen, na?
Yeah, your screen is not seen. You can do what you want.
Okay. Okay. So
Yeah,
now
but
only
if
we
you
three are talking,
have
or everybody can hear?
no, it is only the three of us right now.
Huh. Okay. Okay.
Yes, so we're waiting for Dr. Kothari and Dr.
Where is
Berger to
Dr.
join.
Burger, as in McDonald burger, right?
Yes, but the spelling is different. It's
Yeah.
Berger.
Okay. Wow.
Even I assumed it to be Berger because Berger
Yeah.
paints.
Yeah.
But when he introduced himself last webinar, He said Berger, and then I realized that it is Berger, not Berger.
Oh, that's a good tip. So he's already done a webinar during the COVID thing.
Yeah. I think about 10 days ago or so.
This is his third, I think. He's done one on
Okay.
PML, one on neurosyphilis.
Okay.
And neurosyphilis was, I think, the first one he did for fine at least.
Okay.
No, wasn't the PML for
Oh,
us?
yeah. You're right. The PML one was also there. Yeah, so this is the third one.
Okay. So I missed both of them. How are you, Ratnavali? Good?
I'm good. How are you?
I'm good. So what's the work schedule like? Are you going physically to the
Clinic
hospital?
closed, so.
Yeah. So, but you all have online consultation now, or?
We have it in Manipal Hospital, but I'm not going to Bangalore. I'm in Mysore.
Yeah. Yeah.
So if I was in Bangalore, I would be doing the video consultation.
Yeah. Okay. Yeah. It's a tough life, no? Just
Yeah.
be at home.
Yeah, but it's tougher for people who are
who are ill, na?
worse rates than us. So.
Yeah. Yeah. So in our
are you going to introduce him?
Yes. You want to introduce him?
No. Because they haven't told me that anything.
Okay, so now we are at 8:18. So I think, see, right now it's only the three of us. I haven't opened the meeting for everybody. Do you think I should?
I have no clue. Means, yeah, I think go ahead and do it.
Sudhir is not yet there.
Yeah, he's not yet joined. I don't know when he will. So
you can wait for another 2-3 minutes, I think.
Yeah, so like dot 8:20 we'll open it up. It's already 19 now. So we'll wait for a minute.
Yeah.
What about you? Are you going to work?
So we are admitting COVID and non-COVID patients, and we have online consultation also. We split it in the department, so we go in rotation. So yeah, I'm going to work then, but I think for an hour or a couple of hours, not more, because the hospital is drastically cut down regular work.
Correct. The regular OPDs.
Yeah, the regular OPDs. But it's kept them open. So if there is an emergency, otherwise there'll be panic. Where do you go?
Correct. No, that's
what
not
is in Bombay being a hot zone, what has happened is small nursing homes and all are closed. Most of them. So people don't know where to go and what to do.
Apparently, even the larger hospitals are closed. Here in South Bombay, at least, like I think we have only HN, which is open.
That is because they got COVID
cases.
Cases among the healthcare workers. That is for quarantine purposes. But hopefully they should open again, because these are all I think teething problems with dealing with COVID. But I think every few days that you go to the hospital, it is more like a fortress, and even the city is more like a fortress every week. No?
Yeah, it is. You mean to say that it is more and more fortified?
Yes.
Okay.
Yeah. And
I can see Dr. Berger has joined us.
Yeah, he has joined.
Okay.
Hi,
Dr. Berger.
Good morning.
Morning.
Or good afternoon, whatever it is there.
Good evening. Good evening.
Evening for us.
Oh, it's evening, yeah.
Yeah.
Well, it's morning here. Sort of, just the end of the morning.
Yeah.
It's around 8:30 here, so.
Pardon? Okay. I'm sorry, what was that?
I said it was around 8:30 here.
Oh, yeah. So it's a quarter of, well, let's see. I have 10 of 11.
Oh, okay. So Dr. Berger, can we open the meeting up for everybody? Do you want to start sharing your slide?
Yeah, sure. We can do that. Let me find share screen.
And do you have any videos in your presentation?
I do.
Okay, so before you do the share screen, you will have to do the optimize share screen for video clip.
That's under video settings.
No. You just say share screen once. Just click on the green button.
All right, hold on.
And you got it?
Oh, optimize screen sharing and
for video clip. Yes.
Yeah. Got it.
Yeah.
All right. All right.
Yes.
Do you see it?
Yes. Do you want to sort of go to the video slide and just sort of check how it's playing?
Yeah, sure. Let me end the show. It's easier to. Here's one. Oh, for some reason, it's not playing very well.
Yeah.
Maybe I should reinsert it. Hold on a second. Let me do this.
Okay.
Duplicate slide. Take this out.
Hi.
Okay.
Hi.
Yeah, so I've had this
Hi.
problem before. It's something with the codec doesn't like. It usually means I have to
Some
turn it
video is not
into.
working. Is there some video which is not working?
Yeah,
We're
yeah.
just checking the videos.
Can you just email that fast to me? I will edit it and send you back immediately. I've got a
Okay,
program
all
to
right.
edit the videos.
How do, so who am
Just
I
email
talking
me.
to? Pardon?
Sudhir Kothari.
Oh, it's Sudhir. Okay, all right.
Just email me fast.
Let's see, that's not what I
Sudhir
wanted.
Kothari at gmail.com.
You're here, right?
This is a video of the myoclonus or what is it?
Yeah, it's a video of myoclonus. I might have another one in there, but
Okay.
this was a patient that PowerPoints, CJD movie. Yeah, that's it. I mean, I could do it as well.
No, I have time, so you can go about. I'll send it back in 5 minutes.
Okay, all right. For some reason, let's see, cancel. Let's do this again.
Hi,
Maybe it might be because it's.
Hi, sir.
Hi, how are you?
Good. So you're keeping us all on our toes with these webinars.
No, all these guys are doing the job for me. I'm just getting them. Okay, I got the video.
Oh, you got it? Okay, good. You sure? Doesn't look like I sent you anything.
Is it playing on your desktop outside the PowerPoint slide?
Yeah, no, for some reason, doesn't seem to want to. Let me see. Let me make sure I don't have any other videos in there. I can't remember what I have in there. Let me delete this because I copied it. Oh yeah, here's another one. Let's see if this one works. Yeah, that one works.
Yeah.
That one's working, yes.
Yes.
Joe, what you can do is you send it to me. I'll send it to you back, and you can show it later before the
That one works.
before the end of your talk. You can show it by that time, so you can.
And that one works. Yeah, it's only that one video. You know what? I think I might have something else to show the myoclonus. Hold on, let me see what I have. Walking CJD. Oh, here's a startle response. All right, let me see. Insert video. let me try this. Oh, that one works.
Close your eyes, just relax, take some deep breaths, just relax. Like pretend you're going to sleep.
That's a good one. Let me put that one in.
Yeah.
Hi, Sudhir.
Hi, how are you?
I'm good. How are you?
I'm fine. Keeping myself not getting demented.
You're doing such a wonderful job. I really feel I can hear my neurons pop.
No, basically it is to prevent getting into some sort of depression or something. You know, as I told you, I am alone here, only my dog and me. No maid.
Where's the family?
My wife has gone to USA. My daughter
Oh, okay.
deliver.
Oh, congratulations.
So Anju is there.
Mm-hmm.
All right, were you able to change that? Because I'll stick it in real quick.
Yeah.
And I'll take this and I'll move it somewhere else. So let's see where I'll move it. Let's move that there.
You get a question on thyroid. I'm sure Hashimoto and things people are going to ask.
Sudhir, were you able to convert that?
I haven't got it yet. 1 minute.
Usually you go right online and do that.
I haven't got a video yet from you.
Oh, I thought you got it. Okay, all right. No.
Somebody sent that you explaining neurosyphilis that on the YouTube. That somebody sent me. I thought that was you sent me. No, but I haven't got a video. Let's email it.
Let's see, what do I need to convert this to? I just need to figure out what I need to convert it to. It'll take me 2 seconds. What is this? A WMV or something? .mov. Let's see, this one works. What's this one? Properties. Type of file, M4.
WMA, it will work if you make it. Is it a MOV file?
And that, I don't know what it is. I'll look it up. It's an AVI file, so I have to make the AVI file
into a WMA or a MOV. You want to?
Yeah. All right. So let's see. There's one that I do all the time. Convert files. It shouldn't take very long.
No, it should be. There are online places also. You have a Mac or you have a PC?
No, I have a PC. I never got into Macs.
API to
browse PowerPoints, CJD. File name. Oh wait, do I want to convert? I don't want to convert it to an MPEG. I want to convert it to an MLV. How about WMV? Would that work, you think?
Dr. Kothari? Oh, we've lost Dr. Kothari. Mansi, are you around?
Yes, I am. Yes, I am.
So Dr. Berger is asking, would WMV work for video?
Yeah, it would work, but the only thing is this more depends upon your configuration, not really Zoom. It depends more upon your machine's configuration.
If you can play.
Yeah, no, I realize that.
Yeah, so what we'll do is you could play in that format and we'll tell you whether it is playing.
Okay, all right, it's uploading, so it's converting, and we'll,
Okay, okay.
let's see, if I want to make it an MOV, I don't even know which one the MOV is, MPEG. Oh, here it is, QuickTime, MOV.
Click the browser button in the bottom left.
You got it? Otherwise, just email it, Joe, and we can start.
You know what? Yeah, let's do that. Yeah, we don't even need it. I mean, I'll try and send it to you though.
Send it. By the time you finish your talk, I will email it back.
All right.
So you can show it in the end.
All right.
Also, so if you think that the newer format is working on your machine, then I think it shouldn't be really a problem. It will play. I'm guessing so.
You know, it's not letting me send it to you for some reason.
It may be very large for an email. So
yeah,
it's probably too large. You know what? Let's not worry about it. It's not the end of the world.
Okay. Can you play it without inserting it into your PowerPoint on your desktop?
No, it's not working. So, but I have enough videos that work. Okay. It's not that big a deal. Okay. All right. So, can you see my screen now?
Yeah.
Yes.
All right, good. So, should we get started?
I'll introduce you. Have you opened it for the attendees?
I just opened it up. So
okay.
Wait.
Yeah, we already have around 50, 60. The count is just...
Yeah, I think we'll wait for a couple of minutes because we've just opened it up. Yeah.
Just opened it up.
Okay. If we're waiting, well, all right. I'll convert this thing later.
Joe, do you have vtransfer.com? Just go to vtransfer.
No, I don't have that.
No,
Google Drive.
Just go to vtransfer. You don't need, it's online only.
Oh, it's something in Google?
Yeah, no, just vtransfer.com. Just enter in your browser.
Okay, email a large file?
Send a large file. Just send that. It's the simplest way to send a large file.
It says visit website, buy this domain.
So you just sign up for free, no nothing. Don't sign up, just say no thanks and add the file and send it.
Visit website, be large and fed up with file limit size.
You don't need to sign up, you just send.
Okay.
And my email is Sudhir Kothari, SUDHIRKOTHARI @gmail.com.
Yeah, one's 99 cents.
No, nothing. You signed up probably.
No, I never signed up. I don't know what this is.
They should not charge it.
You know what? Don't worry about it.
I think
it's not the end of the world.
Do it later.
Yeah, we'll figure it out some other time.
So
yeah,
we have 250 people.
250, you can. I think,
we'll wait for 2 minutes more because we've just opened it up.
Okay.
All right. Well, as they're signing in, I'll try something else to see if I can't do it.
I think all neurologists are a little bit of OCD, you know.
Yeah. All right, let me see here. I've done this before, so what did I say that was? An AVI file. And there's one that I like using that I've used before. Online converter video converts. Yeah, I don't want to download anything. Just want to do it online. Convert AVI, try that. Right. Convert. All right, I'm converting it now, so
Great.
Oh, good.
it shouldn't take much longer.
So we're just waiting for 2 more minutes to.
Yeah, that's fine. That's fine. Yeah, I feel bad when it's less than 500 people in the audience.
Yeah.
I mean, after all, it's India. My God, that's like 0.00001% of the population. I don't know.
But
Absolutely.
we only invited neurologists.
Oh, is that? Now that explains it. Now you tell me. I thought I'd have Modi on the call with me.
Yeah, and compared to the population, the number of neurologists is minuscule. You got more neurologists probably in one state of USA than we got in India.
Is that right?
So we got hardly, how much is it? 2,500?
Practicing must be even a smaller number.
Maybe 2,000.
Yeah, you do. You have a much smaller number of neurologists, but the internists do a lot of the neurology there. I mean, who takes care of your strokes? Doesn't the internist do that?
Oh, yeah.
All right, we're 2/3 of the way through, actually a bit more. So then I have to insert it.
So we are at 300. So the participant number is also creeping up.
Okay, all right, open.
We can start anytime. Joe, you're ready.
Okay. All right, give me 1 sec. Let's see if this thing works. You know what? I think it wants to insert something on my computer. So I'm not so sure of this. Yeah, all right. Yeah, you know what? We're going to just proceed without it. All right, let's go back to the screen, and somebody was going to introduce me.
Yeah. So it gives me great pleasure to introduce Professor Joe Berger today. And we have heard him before in the last 2 weeks. He's a professor at the Hospital and University of Penn, and he heads the Multiple Sclerosis Division and the Neurology Department. He's had a substantial contribution in understanding HIV, and his particular research interests have been PML, HIV, AIDS, and multiple sclerosis. In particular, he has contributed to understanding why PML occurs more among HIV patients with HIV than in other immunosuppressed conditions, and has also contributed immensely to understanding the direct effects of HIV infection on the central nervous system and the peripheral nervous system. He is the recipient of the prestigious Pioneer Neurovirology Award by the International Society of Neurovirology, and it gives me great pleasure to ask Dr. Berger to give this talk.
Thank you very much, and the kind introduction. So, as you see from the title, I've taken Creutzfeldt out of the name, and I'll tell you why in a little while, but it really has to do with the fact that Creutzfeldt didn't describe Creutzfeldt-Jakob disease as we understand it. The disease really goes by the name subacute spongiform encephalopathy, and I'm going to discuss it and some other prion diseases. So I'm going to start with a case presentation or two, talk a little bit about the history of the disease, just as we did with syphilis, go through sort of a soup to nuts, the epidemiology, describe sporadic CJD, and I'll use the term CJD since it's so widely used, the diagnostic studies we employ, the pathology of the disease, the spectrum of prion diseases, sporadic, infectious, and familial, the nature of the scrapie prion, and treatment strategies. So this was a man that I saw in Miami back in 1989. He was a 54-year-old man. He was the second highest ranking individual in the county government, who in May of 1989 developed some lightheadedness, trouble finding words. And these problems were noticed right before he went on a cruise. And while he was on this cruise, his wife and his son noticed that his behavior had changed dramatically. His speech became abnormal. He was unable to count backwards by 7. He was unable to name the president and had a CT scan that was normal. So after the cruise, he came back and started being worked up. And on June 30th, 1989, during evaluation, he was disoriented. He had problems speaking and writing. A neurologic consult was performed, and they thought that he had a small stroke. The MRI was otherwise normal. He ultimately had cerebral angiography and ended up in a psychiatric wing of a hospital, not my hospital, some other hospital, community hospital. And I was called in to see him for a second opinion. By the time I saw him, he was essentially bedridden. He was mute, spastic, had myoclonus, and it was pretty evident that he had CJD. So this man had been misdiagnosed initially, and it went for quite a long period of time. I just want to show you his handwriting. So this is when he went on the cruise. Here you see Dolphin Cruise Line. Here he is. That's his handwriting at the beginning. 21 days later, this is what his handwriting looks like. They asked, somebody had asked him to write, had written, what is your job title at Dade County? And this was his handwriting at the time. He had a hard time even spelling county. Here's another man, a 74-year-old man who 10 years later was seen. In May of 1999, he complained of imbalance and hallucinations. He saw big rabbits and people. He forgot how to dress himself. He forgot how to drive places. His MRI was normal. The family noted that his behavior was quite bizarre. He took apart plumbing. He made piles of magazines and other things. He saw animals in the house. In a few days after that, he was totally disoriented. He was putting spaghetti in his magazines. He was admitted again to a psychiatry hospital. So this is a bit of a common theme. And he was there for 3 weeks before he was moved to an Alzheimer's disease unit. And back then, somebody did a brain biopsy and diagnosed CJD. So this is what he looked like on May 26th of 1999. And this is him bedridden in July of 1999. I did have a video of his myoclonus, which unfortunately doesn't play, so I removed it. It was obtained a couple days before his biopsy. This was Creutzfeldt's first description. He described in 1920 a 22-year-old with a 6-year history of weakness, myoclonus, and dementia. One of 3 sisters with mental illness. She had neuronal degeneration and astrogliosis, but there was no mention of spongiform changes. And it's not very likely that this was CJD given the age of the patient. So what precisely Creutzfeldt described is unclear. Jakob, on the other hand, did describe in 3 of his 5 cases what we now call CJD. And the paper you guys should read is by Masters and Gadjusek in Recent Advances in Neuropathology, where they actually go through the initial descriptions by Creutzfeldt and Jakob and make the case that it was Jakob that really described these patients. So Jakob's case, of which I guess it was only 2 of the 5 cases had a transmissible spongiform encephalopathy. The 3rd case was a man. He had aching legs, vertigo, abdominal discomfort at the onset, diplopia, dysarthria, ataxia, and at 6 months was confused with no recent memory, myoclonus, spasticity, and dysarthria. And the 5th case was a 38-year-old woman with a slow dysarthric speech, facial twitching. She progressed to myoclonus, ataxia, abnormal movements. And both of them had all the characteristic histopathology, the spongiform changes, the astrogliosis, and the neuronal loss. So they felt that really only 2 of the 5 cases that Jakob described had what we now call Creutzfeldt-Jakob disease. The incidence is roughly 1 in a million. The peak incidence is between the 5th and 7th decade. Familial cases generally develop at age 51 and sporadic cases later at age 58 on average. 10 to 15% of the cases are familial, and this is an autosomal dominant inheritance. The gender distribution is equal, and survival is poor, with the overwhelming majority of people dead within 1 year. Now, it's got an unusual distribution worldwide, and this was recognized perhaps initially by Esther Kahana. Esther Kahana with Milton Alter was the person who described the fact that if you move from a community where MS is high to one where MS is low before the age of 15, you acquire the incidence rate in the community to which you moved. And if you move after the age of 15, and these were studies done in Israel, then you had the high rate of the community that you came from. She did another study looking at CJD, and what they found was something very, very interesting, that Libyan Jews of Libyan origin, had this incredibly high incidence rate of CJD compared to the Jewish community otherwise in Israel. And that rate, by the way, parallels the rates that are seen elsewhere. Now, it turns out that this Libyan Jewish community came from this small island called Jerba off the coast of Tunisia. And this community had been there for more than 2,000 years, was highly inbred, and actually turned out to have a familial form of CJD. The sporadic CJD is pretty equally distributed, but familial CJD is not. And it depends on what the population is that dictates what the incidence rate's going to be. There's a clinical tetrad of CJD. It's a subacute dementia, myoclonus, a characteristically abnormal EEG, and normal CSF findings. This comes from a study by Thomas Weber, who was commissioned by the German government to look at the incidence of CJD in Germany at the time that mad cow disease was prevalent. And what he found was that fatigue was present in 56% as a prodrome. An altered mental status occurred early in about 50%. Depression as well. Loss of weight was common, altered sleep patterns, abnormal eating, and abnormal sweating, all prodromal symptoms. In terms of signs and symptoms, virtually all had rapidly progressive dementia. Almost all ultimately developed myoclonus, and a very high proportion, 84%, had cerebellar findings. 71% had extrapyramidal findings, 54% akinetic mutism, and 49% pyramidal tract signs, with a very small number having sensory symptoms, but they can. And one of the things we see is startle myoclonus. This is one of my patients.
I'll tell you what, close your eyes, just relax, take some deep breaths, just relax. Like pretend you're going to sleep.
And you see the startle myoclonus that she exhibits. This is a patient that we saw in our clinic at the University of Pennsylvania who actually presented with a movement disorder. He's a 72-year-old man with chorioathetoid movements of the right hand of 1 month's duration and mild cognitive impairment. And he's being examined here by Dr. Mike Rubenstein.
Good. Okay, now put him down for me. Okay. Now with your left hand, let's do this. With this hand, go real fast. And you're right-handed, correct?
Yes.
Go real fast. Okay. And now let's do it with your right hand. Try to go as fast as you can for me.
So the point to be made is that at onset,
Now what I want you to do is on your leg, I want you to go like this
you
with your right hand.
may not see much in the way of the cognitive changes. It may present in some other fashion and be extraordinarily confusing.
Okay, and now let's do it with your left hand. Okay. Now what I'd like to do is go ahead and tap my hand with your foot. Just go up and down like that. Good. Okay, and now tap this one. So that works pretty good there.
This was his MRI, and you see this cortical riveting so characteristic of CJD. His EEG at the time showed diffuse slowing, and his CSF was negative with respect to 14.33 at this time, but the reverse transcriptase quick test for CJD was positive, giving him a 98% probability of CJD. Now, there are different clinical types of CJD. This type that presents with basal ganglionic features and dyskinesias has been referred to as the Stern-Garson type. The types that we see perhaps a little more frequently include the Heidenhain type, where the person presents with cortical blindness and visual agnosia. And when I say present, this is before they have the rapidly progressive dementia, which ultimately intervenes. And then there's a form called Bernal-Oppenheimer, which is an individual that presents chiefly with cerebellar features and has normal intellect in more than 50% of the cases when they first present. The frequency with which this was seen in one series was 17%. It can present in many different ways. So it is a disease that you always have to have in the back of your mind when you're examining somebody as a potential cause. And I often see patients where a diagnosis can't be rendered at the time I first see them, and I say that we just have to wait it out and we'll figure it out. And this is often the case when these patients present with other than the rapidly progressive dementia. So it can present in a stroke-like fashion. It can present with seizures or blindness or ataxia or extrapyramidal disease, as I just indicated. It can present with lower motor neuron disease, focal brainstem involvement, autonomic dysfunction, and supranuclear palsies. So this was an experience, I'm not sure I wrote this up, I can't remember, but from 1974 to 1983 at the University of Miami, this in part was chart review and in part my own experience that I collected, because I was there from 78 to 94. I found 24 cases. The age range was 30 to 86. The mean was 60 and the median 61. Was pretty equal, men to women, 13 and 11. 3 of the 24 were healthcare workers, and I did write that up. And we'll talk a little bit more about that in a second. As people in the healthcare industry, certain types of healthcare may be at increased risk. There was one familial case, and the initial diagnosis was incorrect in 17 of the 24 patients. 7 of them had psychiatric disease, 4 were said to be encephalopathic for a variety of reasons, 2 were thought to have had a stroke, 2 were thought to have MS, 1 was said to have epilepsy, 1 Parkinson's disease. 15 of these patients underwent biopsy or autopsy to confirm the diagnosis, and 1, the biopsy was falsely negative, but when they came to autopsy, they had a thalamic dementia with the changes chiefly in the thalamus and were proven to have the disease. Here's a patient with a Parkinsonian presentation, 70-year-old retired telephone worker. He developed tremors 2 to 3 years earlier that had gotten progressively worse. 6 months ago, he had imbalance, fell backwards, shuffling gait, moderate memory loss. His speech was softer, became hypophonic, difficulty turning over in bed. So rapidly progressive Parkinsonism, and he complained of numbness of his feet. And on examination, he had a tremor, he had a tendency to fall backwards. His gait was ataxic, he had postural instability. The impression was that he was more ataxic now than he had Parkinson's disease. He had no improvement with primidone, increasing confusion, falling, unable to support himself, stand or walk. And this was his MRI. And you see that on the diffusion weighted imaging, the very characteristic findings of CJD, the Stern-Gerson form of it here, where the basal ganglia is involved. This is the sporadic form of CJD, where you see the cortical ribboning, but you do see the involvement of the thalamus and the head of the caudate. These are just some other imaging studies of patients. Here it is, again, this cortical ribboning and the hyperintense signal within the basal ganglia. And they're not diffusion restricted. These don't diffusion restrict. Involvement of the thalamus. This is an older patient of mine. And here's the typical EEG with triphasic periodic complexes. Now, it may be that these only occur at a certain stage of the disease, so you might miss them early on or very late in the disease, and therefore the EEG should be repeated. When the patient's exhibiting myoclonus, very often you'll pick these up. So the criteria, the CJD criteria, this was from a paper by Steinhoff in the Annals of Neurology in 2004, is that there should be a strict periodic potential, 100 to 600 milliseconds, with intervals in between of 500 to 2000 milliseconds. They can be generalized or lateralized, and there are at least 5 repetitive intervals that you'd like to see. And it has a specificity of 91%, but the sensitivity is not that high. Pretty high positive predictive value, though. And then, of course, you want to look for 1433 in the spinal fluid. This is an immunoassay, and it has a very high sensitivity of 96%, specificity of 88%. And we now have other tests, which I'll talk about. Just the 1433, by the way, is a highly conserved sequence found in different species. It's got a molecular weight of 30 kilodaltons, and it is a portion of the plasma membrane that's involved in signal transduction. So when you put these together, and this comes from a paper by Thomas Weber, if you put them together, you can see what the sensitivities and specificities are for each of these. I would say that the MRI, the sensitivity and specificity is actually higher for the MRIs. We've understood more about the disease, and probably are relying more on diffusion weighted imaging in it. And then CSF tau is elevated in individuals with CJD far more than in individuals with Alzheimer's. So the average increase is 58-fold in CJD, whereas it's only 3.5-fold in Alzheimer's disease. But both CJD and Alzheimer's have low A beta 42. So another CSF test. But the test that we really rely on these days is what's called the real-time quaking-induced conversion assay. I'm not sure that that's available in India. I presume it is. And what it is a quaking-induced conversion where it converts the PPRC, which is the soluble prion protein, to the PRP-SC, which is the scrapey protein that is insoluble. And it has a 98% specificity and a 91% sensitivity in CSF. You can also do the test from samples obtained from olfactory mucosa. And in those instances, the test is probably about the same specificity, but or sensitivity rather, but 100% specific. And of course, there's always relying on the biopsy. There's always concern, though, of sampling error with the biopsy or autopsy. And what you want to see is the characteristic triad: spongiform changes. These are unique and distinguishable from the spongiform changes one sees artifactually. Gliosis, this is always present. and neuronal loss, which is an important component as well. And these neurons are surrounded by these microvacuoles. This is just brain atrophy. It could be in anybody. It doesn't necessarily be in CJD. But here's the microvacuolization that one sees. So these are little blebs that occur. And the gliosis that one sees, the vacuolization. And amyloid may be seen as well, but only in a minority of individuals. So amyloid plaques are seen only about 5% of CJD, though there are certain forms of prion disease where they appear to be abundant, such as in Kuru and Gerstmann-Straussler-Schenker syndrome. So here's a amyloid by light microscopy with a Congo red stain, and here it is by electron microscopy. So these are the diagnostic criteria. Definite CJD is where you have the neuropathology, or alternatively, the immunocytochemistry or the presence of scrapie fibrils. And then, of course, there's probable and possible, and it's a combination of having these clinical laboratory features to support the diagnosis. This is just another diagnostic criteria that had been proposed. I won't go into it. And there's a spectrum of diseases. So the patients that I presented to you were all sporadic CJD cases. But there's infectious CJD and there's familial CJD, or transmissible spongiform encephalopathy. The infectious forms are Kuru, iatrogenic disease, and then there was the new variant, which is not so new anymore, CJD, which was what we experienced when mad cow was a problem. Under familial disease, there's familial, more or less typical CJD, Gerstmann-Straussler-Schenker syndrome, fatal familial insomnia, and thalamic dementia. They're the syndromes that one considers. So let's talk a little bit about these. Kuru is the prototypic infectious form of transmissible spongiform encephalopathy. It was described in 1957 by Zigas and Gajicek in the Four tribe of Eastern New Guinea. And what they found when they were out there were that these people who spoke this particular language called the Four language, so that, and they were a very isolated community, had this illness where individuals would become demented and ataxic and die at a young age. And they had these characteristic changes in their brains. And Gajicek decides to present this at the Wellcome Museum in England. And he has a poster up describing this illness, and a veterinarian from Colorado by the name of Bill Hadlow happens to be visiting England, and he visits this museum, and he realizes that this illness that's described in the poster by Gajicek, who, by the way, had no idea what caused this illness, he suggested that this had similarities to a disease seen in sheep that had been described 200 years earlier, if not longer, referred to as scrapie. And it was after that that they realized that you could actually transmit this disease to primates. And Gajicek, Gibbs, and Alpers do that in apes with an average incubation period of 18 months, taking the extracts of the brains of these patients, putting them in apes. And they did that at the NIH. And for that, Gajicek won the Nobel Prize. Of course, Gibbs was every bit as important and unfortunately didn't receive that recognition. And it was also recognized that these people in this area of New Guinea, this tribe, practiced cannibalism. And the form of cannibalism they had is when somebody would die, they would distribute parts of the tissues, and the women would get the parts of the body, women and children would get parts of the body that men seldom got, and therefore the rates of illness were much higher in women and children because they would get brains and other tissues that had large amounts of prion in them, whereas the men would get the muscles of the deceased individual. So this is the Kuru region where the 4 tribe lives in New Guinea. And the disease is characterized by a prodrome of headaches and limb pains, followed by an ambulant or first stage where they're dysarthric, they have postural instability, ataxia, and shivering, then goes to a sedentary phase with tremor and ataxia, startle myoclonus, emotional lability, and dementia, followed by a terminal stage where they're unable to sit unsupported, they have severe tremors, hyperreflexia, and incapacitating dysarthria and incontinence, and they generally die from either infected decubiti, pneumonia, or they're in a hut with a fire in the center of it, and they can't control themselves and roll into the fire and die that way. And these are women, you see their walking sticks. Actually, I showed that with neurosyphilis in one of Charcot's patients, but these are ataxic women with the disease, again, with the walking sticks. And this was the mortality. So with the abandonment of cannibalism, the rate of the disease fell to virtually nothing by the early 1980s. So it was quite high in the 1950s when it wasn't recognized what the cause was. And then when it was, and people avoided cannibalism, the disease dissipated. The pathology is gross cerebellar atrophy, amyloid plaques in the cerebellum, granular cell loss, neuronal loss, intraneuronal vacuoles, as we see with CJD, astrocytosis, and as with CJD, no inflammation. Now, there's another form of infectious disease, the iatrogenic form. And the commonest cause used to be human pituitary growth hormone. But nowadays, we engineer the growth hormone. So it's not obtained from pools of pituitaries that are mashed up and the growth hormone retrieved from. But at one time, it was, without question, the commonest cause. Human pituitary gonadotrophin accounted for 5%. Corneal transplants from individuals with CJD that was unsuspected in 2%, 15% from dural grafts, 6% from neurosurgical procedures, and 3% from depth electrodes. I can tell you that I've been involved in at least 3 instances, 3 different hospitals, where I've been consulted because depth electrodes have been used in somebody with CJD, and then used before they were recognized to have CJD, and then subsequently used in other patients. So these are the incubation periods. So you see that the longest incubation periods appear to be with gonadotrophin and growth hormones, which can take up to 12 years, 6 years for dura mater, but for stereotactic injection or neurosurgical procedure, since you're injecting it directly into the brain, it occurs much sooner. And the clinical presentations may be a little different with each of these. So Paul Brown, who was truly a world's authority on the infectivity of the prions from these different tissues and fluids, had a very nice paper in which he discussed this. And he found that brain, spinal cord, CSF, eye, lung, kidneys, lymph node, liver, and spleen were all capable of infecting people, less so other tissues. But it isn't zero, okay? So even though it says negative tissues and fluids, this is not really zero. And there are low concentrations of the prion that have been found in the blood, as Stan Prusner demonstrated. And there's been at least one case of an individual who, with variant CJD, who developed it after a transfusion, 7.5 years after somebody who had donated blood and had variant, or the mad cow form of CJD. It is present in skeletal muscles of animals, but in far lower concentrations than in others. Now, I show this only because this is Gajasek and Zegas and Berger, who are in New Guinea. And these are the brains of the patients that have Kuru. And here they are eating. They have like specimen bottles on the windowsill and brains on the table. And they're eating in the presence of all this. None of them died of CJD, but it is an interesting picture. So the history is, as I told you, that Bill Hadwell was the one visiting the Wellcome Medical Museum who makes this observation and says, wait a minute, maybe this is an infectious disease like scrapie. Now, there's a third form of infectious disease that fortunately we're not seeing anymore. It was recognized in '85, became known as mad cow disease, and it occurred because of the use of meat products that were infected with the prion in herds that would not ordinarily eat meat, but they were supplementing the feed stock for these cows. And in 1989, there was this ban of offal from for UK beef, and then the United States banned British beef. And you see that over time, the number of confirmed cases, and this is amongst animals, was not insignificant. They had to cull their entire, the British had to cull their entire livestock herds, their cow herds. And this is what a cow looks like with mad cow disease. So the cow's a bit ataxic. And this is scrapie. So scrapie's been around, recognized since the early 1700s. It went by a number of different different terms in different countries. It got the name scrapie because, as you see here, the sheep would go up against the fences. They had pruritus, and they'd scrape off their wool. And this is a picture of a sheep with scrapie. Again, the sheep's ataxic. So this simply tells you the forms of animal transmissible spongiform encephalopathy. Sheep, it was seen in 1730, and goats in 1942. Mink encephalopathy in 65. In the United States, we have a form of the illness called chronic wasting disease of mule deer and elk. That was first recognized in 1967. There are apparently a substantial number of herds in the West that are affected, and this becomes an issue because people actually shoot these deer and elk and eat them. Was seen in captive primates in 1999. So it's not as if there aren't other species that aren't affected by this disease. The new variant disease, this is from '96. I haven't updated this, but I should. Will found 10 cases since May of 1990. It had been declining. The features are that it affected people much younger than typical CJD. They started out with neurobehavioral abnormalities and ataxia, and very often complained of dysesthesias and pain. The late features included myoclonus, chorioathetosis, and dementia early on was seen in only 20%. It had a very protracted clinical course. There were no periodic complexes. You saw spongiform changes that were most evident in the basal ganglion thalamus and lesser changes in the cerebrum and cerebellum. And it was often not recognized as CJD until people came to autopsy. Some of the important components of this paper are that all of the patients had early psychiatric symptoms. And it's a disease to keep in the back of your mind when you're confronted with somebody where there's no family history of psychiatric disorder, particularly if associated with other neurologic features like ataxia or movement disorders, which with decreased cognition develops within 6 months. And the CSF 1433 was positive in only 15% of these cases. Interestingly, with respect to the prion genome, all were homozygous for methionine at 129, which is not true of the population at large. And you see here that by 2009, the frequency with which variant CJD was seen in the UK had declined very, very considerably. So there appeared to be a genetic predisposition to this illness as well. And this was, I won't belabor this, but there were a number of different assays developed for it, including a bioassay in a mouse, immunohistochemical immunoassays, and conformation-dependent immunoassays. So we've talked about this. There are prion diseases in animals that may be of some relevance. And now let me talk a little bit about the inherited transmissible spongiform encephalopathy. So you have familial CJD, Gerstmann-Straussler-Schenker, fatal familial insomnia, and thalamic dementia. And where the mutation is in the prion protein, prion genome, dictates what sort of expression you're going to have, what sort of clinical expression. So Gerstmann-Straussler-Schenker is an autosomal dominant disease. It develops generally between the ages of 43 and 48, and it's a progressive spinocerebellar degeneration with late onset of dementia. Generally, people die within 5 years. Fatal familial insomnia also, these are all autosomal dominant diseases. The onset's 31 to 61 years old. These people develop intractable insomnia. They have sympathetic hyperactivity, endocrine imbalance, dysarthria, motor abnormalities. Dementia is not particularly prominent, although I would tell you that if I were insomniac for days on end, I'd probably be demented. The hallucinations they have are enacted dreams, and it is fatal in 13 months on average. So this is the epidemiology of familial CJD. You can see that relative to sporadic CJD, it's a very small component of the number of cases. And the same is true of iatrogenic, which is in green. So these illnesses were initially, before it was discovered by Prusner that this was an infectious protein, this was thought to be a virus. And Sigurdsson in 1954 had classified viruses, developed a classification called slow viral infections. PML is a perfect example of a slow viral infection. Subacute sclerosing panencephalitis is another perfect example. And it was thought that CJD was probably the same. That is, a long initial period of latency from months to years, a protracted course that leads to disability and death, and limitation to a single host species and anatomical organ system. But very early on, it was thought that it was unlikely to be a virus. And this comes from work done by Tikva Alper in London. She actually should have won the Nobel Prize for her work. And what she showed was that the scrapie agent, unlike viruses, was extraordinarily resistant to radiation. So much so that it couldn't have nucleic acid in it. Okay, so, you know, all these other things, you shine the X-ray beam on them and they die, but that wasn't true of scrapie. And that ended up leading to a series of experiments that Stan Prusner did. Here's Tikva Alper. Stan, by the way, was a graduate of the University of Pennsylvania and a resident in neurology at the University of Pennsylvania. And this was a series of experiments that he describes in a beautiful Scientific American paper in 1984, where he demonstrated that this is infectious, that you can titrate it so that at different levels it becomes less and less infectious, and that if you were to expose it to a protease or other things that affect proteins, it loses its infectivity, whereas when exposed to things like nucleases, ultraviolet light, and zinc, which disturb nucleic acids, it remained infectious. So it suggested that this was really a protein, and not a nucleic acid. And in fact, you could expose it to proteases and then to certain forms, like you can chemically modify a protein with this diethyl pyrocarbonate, and it loses its infectivity. But then if you expose it to hydroxylamine, which then modifies and reverses what you've just done, you can restore the infectivity. So it was pretty convincing evidence that this was likely to be an infectious protein. And it is this that he won the Nobel Prize for. They're classified into strains based on incubation time, host species, and neuropathology. After their injection into susceptible animals, and by the way, it is the prion protein SC that is the culprit. We all code for prion protein C, which is a soluble form of the protein that exists within caveoli of cells. And if you inject this PRP-SC into animals, you can detect it in 7 days. It demonstrates this rapid linear increase and spreads throughout the brain, disrupting neurotransmitters from synaptosomes. So this is what the normal prion protein looks like. This is what the disease-causing protein looks like. And what it does when you introduce it into the body is that it takes the normal prion protein that is otherwise soluble and it converts it into an insoluble form. So what I liken it to is rock candy, where you take a supersaturated solution of sugar in hot water, you stick in a string, and then you wait, and it starts to crystallize around that string. And that's pretty much the same. It's the disease that occurs sporadically is one that is stochastic in nature. So any of us are at risk, but there must be these enormous barriers to the development of the disease. And it just so happens that one day you develop this PRP-SC, and it starts to procreate, so to speak, by converting PRP-C to PRP-SC. So it is a simple matter. It turns out that certain mutations, and mutations is probably not the right word, polymorphisms, I should say, at codon 129 in the human prion protein increase your risk of sporadic CJD. So that if you're a homozygote with methionine, present only in 37% of normals, yet it's present in 72% of the individuals with sporadic CJD. And these variants, these polymorphisms can dictate how you're going to present. This paper by Castellani in 2004 on that very thing. What about sterilization? I mean, this is a protein after all. So what are the effective means of inactivating it? Steam autoclaving for an hour at 132 degrees centigrade, or 4.5 hours for 121 centigrade, immersion in sodium hydroxide. But it turns out that boiling, UV irradiation, ethylene oxide, ethanol, formalin, all those things that we typically use to sterilize instruments is inadequate. And that's why the disease can be transmitted by surgical instruments. Strategies for treatment include blocking conformational changes or trying to increase the clearance of existing proteins. There have been a number of things that have been proposed. I have them listed here, things like beta sheet breakers, quinacrines, chlorpromazine. None of them to date have shown any efficacy. I've shown you this already, the diagnostic criteria, and I'll leave you with a couple cartoons. This is when mad cow disease was a big issue. Refresh my memory, honey, when were we in London? Did we have the beef or the chicken? And she's sitting there with obviously the beef. And then the question is, how can you tell a mad cow, how to identify a cow with mad cow disease? So if the cow sounds like that, you could fire up your barbecue. And if your cow sounds like this, you better not. So on that, I'll leave it. That's the CJD talk. Questions?
Thank you very much, Professor Berger, for this excellent, fantastic overview. And I've heard Michael Geschman several times, and he mentions the same thing, that it should be called Jakob disease and not CJD. But maybe it's time we should change the name.
Well, we've done that for other diseases. For instance, Halle-Worden-Spatz. We got rid of Halle-Worden because he was a Nazi. I think there's a backstory to Jakob and Creutzfeldt as well. If I'm not mistaken, Creutzfeldt might have been Jakob's student, and Jakob, being Jewish, was persecuted by the Nazis.
Okay.
So they,
yeah.
Go ahead, Ratnavali. Okay, so there have been a number of questions during your talk. Some are on the phenotype of the prion disease, on why why are children spared and young adults spared, and why cranial nerves are not involved as a part of the phenotype?
Yeah, so I think that's a terrific question. So, I mean, if you have a familial form of the disease, and you have this, you're already coding for a prion, why isn't this disease expressed earlier in life? And quite frankly, I don't know the answer to that. Somebody does, but I don't. I think in part it has to do with the fact that it takes a while for you to develop enough of this protein in order for you, or this, the abnormal protein for you to manifest the disease. But there may be other things as well that contribute, such as features of the developing brain that decrease the likelihood. But it generally takes till early adulthood, till you're in your 40s or so, before you see individuals succumb to familial disease. So it's an intriguing question. Why is it that we don't see it in much younger people?
Then there are questions on the testing for CJD, and a number of attendees have asked, what is the explanation of the cortical ribboning sign that we see on the MRI?
Yeah, off the top of my head, I can't tell you what the precise cause of it is. My suspicion is that it's a consequence of the gliosis and the microvascularization that one sees pathologically. That would be the likeliest explanation for it.
Yeah, that would inhibit the free water movement and be diffusion positive.
Right.
Then there are questions that, would you check for autoimmune encephalitis in all patients you suspect CJD, and how extensive a panel would you ask for?
Yeah, so that's a great question. And we've had instances recently at the University of Pennsylvania where individuals have come in who've come from extremely well-read families. And they've had unquestionable CJD based on the MRIs and the spinal fluid findings. And the families have insisted you need to do autoimmune profiles as well, because the seizures they're having, the dementia they're having, could be the consequence. I can tell you that I always succumb to doing those studies. Not that, where you don't know what the answer is, I think it's important to do it because they can present very, very similarly, particularly early on, where you don't see the MRI changes that convince you, or the CSF studies are waiting to come back, because we have to send them off to Cleveland to get the quaking protein, the quaking RT-PCR done. So I do them as a matter of routine, and I usually do a fairly comprehensive battery because, after all, the University of Pennsylvania was one of those sites that where we have a very good group of people that have been investigating autoimmune disease. Joseph Dalmau, for instance, was part of our faculty. Eric Lancaster's here. So we have access to that. But I think it's not an unreasonable thing to do, since one's treatable and one isn't. And it is it's in the differential diagnosis. So I would argue that, unless you have confirmatory evidence, I would do it as a matter of routine.
Joe, the question is also, many times in India particularly, we may not be able to do the test. So do you treat it? Do you give methylprednisolone? Do you give IVIG? Because many people say, might as well give, because it's, what if it is positive? And if somebody...
So I understand perfectly. So I could tell you that the last 2 patients that I've had on my service with CJD have received steroids, IVIG, and I think I might have plasmapheresed one, thinking that they had CJD, but was giving them the benefit of the doubt as I was working them up. And of course, none of them improved. They continued to decline and ended up in nursing homes before dying. So I don't think it's an unreasonable thing to do. I certainly have done it myself, where you're not sure. You don't have enough diagnostic bandwidth to tell you.
Okay. Then the big questions on why does prion disease affect only the brain and not other tissues in the body or the systems in the body?
I don't know the answer to. My suspicion is that if you were to look hard enough, you probably see at a microscopic level some changes in these tissues. It's just that because of the nature of the brain and the importance of signal transduction in the brain, that it just gets manifest by brain disease. We really don't see things like transaminitis or pancreatitis or myopathy. So I think it has to do with the uniqueness of the brain. But I do think that you'll find this prion scrapey protein elsewhere.
Do you see spinal cord involvement in CJD is one of the other questions?
I've not seen it, and I don't remember, but so you can have an amyotrophic form of the disease. That is a form of the illness that looks like individuals have lower motor neuron disease, an ALS type picture. So it does affect the spinal cord. It does affect the anterior horn cells, but I don't recall seeing anything about MRI abnormalities, for instance, where you'd see something that looks like a myelitis. I don't know if anybody's really even looked.
You said about Parkinson's, but there are reports of PSP-like presentation, MSA-like presentation. So if you have a rapidly progressing PSP-like picture, you should look for CJD.
Absolutely. Yeah, I think it can present in any peculiar movement disorder. So when it's rapidly progressive and it's atypical, I think that CJD has to be in the back of your mind.
So the other question is, here we do not have the CSF tests available in India. So many of the questions have been focusing on how to diagnose CJD and how do we communicate to the family? Is it ethical? Because we are relying only on the EEG and the MRI features.
Yeah, I think that so as I alluded to during the talk, I think that the MRI features are sufficiently diagnostic when coupled with the clinical findings and the exclusion of other diseases to make it likely that what you're dealing with is CJD. And if you were to throw in the EEG as well, if you were to see the triphasic waves, that it is likely to be CJD, and you can feel comfortable making that diagnosis.
So you're saying we should exclude autoimmune encephalitis and then we should be comfortable making it.
Exactly.
Joe, if you get a typical cortical ribboning, is that seen in any of the autoimmune encephalitis? Because that typical pattern of diffusion restriction in the cortex?
Yeah, I am unaware of descriptions of that particular typical pattern, but they may exist. I'm just unaware of it. I mean, generally what you see is that the abnormalities in mesial temporal lobes, but occasionally you'll see them in the basal ganglia, very more rarely, or in the cerebellum. So but that cortical ribboning, I'm unaware of seeing it in any autoimmune encephalitis.
I had one more question. We talk about CJD in rapidly progressive dementia, but I have seen some patients who came with CJD, but who had a very slow progress over a year, and they initially looked very psychiatric, looked like depression and late onset anxiety, depression-like symptoms, and then after a few months developed cognitive symptoms, no myoclonus, EEG normal, but MRI showed the ribbon. So it looked very much like a slow sort of dementia over, not over years, but over a year.
Yeah, so that, I mean, I've seen that as well. And in the published literature, perhaps as many as 20% of the cases survive more than a year. So you can see this more slowly evolving course.
So the other questions are, what is the role for tonsillar biopsy?
Yeah, so tonsillar biopsies were really employed, not so much for sporadic CJD, but for variant CJD. We're not seeing much variant CJD, and I must say, I never had the occasion to ask for one. The English were using it at one time when variant CJD was more of a concern. So I can't comment meaningfully on it. It's just something that we're not doing.
A couple of questions on the risk to family members and when they're exposed over a long period. So is there any risk to the family members?
Yeah, so we really don't see that risk to family members. I will tell you that I've worked with pathologists that have refused to do autopsies on patients, and I've worked with pathologists that have told me that they do the autopsy, but the family has to agree to have the body cremated. That they would not allow the body, they didn't want the body to be buried, which I'm not sure makes a whole lot of sense. And as I indicated during the course of my talk, I've had the occasion of taking care of patients that had been healthcare workers or were healthcare workers. Two of them were physicians. One was a physician that was a diener when he was a medical student. So he was making some money on the side being a pathology diener where he's slicing up the body. And the other one had been a pathology resident and worked in a histopathology laboratory prior to changing careers and becoming another form of specialist. So it always raised the question that could you be, as a healthcare worker, at increased risk because of exposure? Now, the exposure would have to be the type where you're susceptible and you're exposed to it in the context of probably tissue, like doing an autopsy. And we're very careful when we obtain spinal fluid on patients that we suspect may have CJD of labeling the plastic bag in which it goes with a warning that this may be a patient who has CJD, so that the people handling the spinal fluid are extra cautious. I imagine it occurs. It's got to be vanishingly rare, and off the top of my head, I'm unaware of any family members in the absence of familial CJD that have developed the disease. Not to say that it doesn't happen, but I'm unaware of it.
So I have one question, and a similar question has been asked about this prion-like spread and neurodegenerative diseases. Would you like to comment on that?
Yeah, so I think that, and I don't claim to be an authority on it, but I do think it's intriguing that there are other proteins like synuclein in Parkinson's where there appears to be a progression, or an Alzheimer's disease with the respect to the amyloid, and the distribution of it over time bespeaks something that is spreading from one area of the nervous system to another, or from the gut into the nervous system. And I do believe that there is probably some veracity to the belief that a number of neurodegenerative conditions are the consequence of these aggregated proteins, like synuclein with Parkinson's disease, for instance. But I think that the answer is still out. I don't think we know enough to comfortably say that that's the case.
There are a couple of questions about transmission through blood transfusions, especially in context of a knee surgery or in general when people receive blood transfusion.
Yeah, I think that that's got to be very unusual. As I said, Paul Brown did not, at least at one time, didn't believe that blood was likely to be very contagious. I think he might have modified that after the Montanid cow scare. And as I said, there's at least one case report of it developing years after a blood transfusion from a patient with variant CJD. So both patients developed variant CJD, which is interesting. I mean, had it been just sporadic CJD, I think you would say maybe that's because they were both, it was one of those rare instances where they both developed it. So I think there's this theoretical risk. There's nothing that we're doing to screen blood for CJD before we give it. And I think it, in large measure, it has to do with the incidence of the disease. You're talking about a disease that's present in 1 in a million people. So
would you be worried about giving immunoglobulins?
I don't think we've seen CJD in people that have received IVIG, for instance. We give an awful lot of IVIG and we give it repeatedly. And I'm unaware of anybody developing CJD after having received IVIG for their chronic inflammatory demyelinating polyradicular neuropathy. So, you know, until we have cases, I'm not sure that it's worthy to be concerned about.
There are a number of questions about the safety of using surface electrodes, and would those need changing in patients who have CJD and versus, say, depth electrodes?
Yeah, depth electrodes for sure. I don't think surface electrodes are really a concern.
Any other questions, Ratnavali?
Yeah. How to differentiate CJD from Hashimoto's?
Well, first of all, Hashimoto's is a misnomer, just like CJD is a misnomer. Hashimoto's is probably better termed a corticosteroid responsive encephalopathy. My experience with Hashimoto's disease, Hashimoto's encephalopathy is that the vast majority of these patients do not have Hashimoto's encephalopathy. I'm not even sure it's a syndrome. I suspect that there are a small number of people, very small, labeled with this, that have a corticosteroid responsive disorder, in which you can see behavioral abnormalities, you could see seizures, you could see encephalopathy, cognitive problems. That turns out to be steroid sensitive, and they have as a marker, but it has nothing to do with the genesis of the disease. They'll have as a marker antibodies to thyroglobulin and thyroperoxidase. And the sense is that this is probably some form of autoimmune encephalopathy that's steroid responsive. But I think that there's some concern that this is a true entity, you know, a discrete entity. So how would you distinguish it? Steroid sensitivity, the presence of thyroid antibodies, the presence of other autoimmune markers. I mean, if you see high ANA titers or ANCA or something like that, you'd say, oh, geez, maybe this is an autoimmune disease. And you treat it as if it were an autoimmune disease. Plus, the EEG wouldn't show the characteristic abnormalities that one sees in CJD. You wouldn't have the elevated CSF 1433, and you wouldn't see the cortical riveting. In fact, the majority of patients that I've seen with what has been called Hashimoto's encephalopathy have had perfectly normal MRIs.
Joe, we've got something which is not really live, the coronavirus bringing the world to its knees. Now, I want to ask, can there be anything smaller than the protein now? I mean, like we found a prion protein which can infect. Do you think there can be anything which is even smaller than a protein which can infect and cause disease? Because
if there is, I'm not sure what it would be. I just have no idea. Might there be other forms of infectious protein? As we talked about with the synucleins and the amyloid, I think there might be, but I don't know what would be smaller or say resistant to the things that we generally use for anti-infections.
There are quite a few more questions. Are you okay answering these?
Yeah, for like 5 more minutes and then I've got to run.
Okay. So you answered about the depth electrode, but what about needle EMG electrode?
Yeah, again, I don't think that that's very likely to give rise to problems. Although we do see the prion protein in muscle, it's there in very, very small quantities. I suspect that, again, and I'm unaware of any cases where transmission has occurred, so I don't think, I mean, why would you be doing an EMG unless it's somebody that presented with an ALS type picture? Chances are you're not going to be doing an EMG on somebody like that.
So do you see
Probably best to throw the electrodes away though. So if you knew.
Yeah. Do you see any new treatments on the horizon? People are asking about rituximab and interferons.
Totally useless for this disease. It's not an inflammatory condition. There's no inflammation. So, doing something to the B cells or giving IVIG or giving steroids doesn't do a damn thing. I think that we might come up with something, but I don't see it on the horizon. I think it's still in the future, talking 5 or 10 years.
Something like we have a monoclonal antibody against things, something like something which neutralizes the protein that unfolding the abnormal protein maybe.
Yeah, well, in vitro, there are compounds that can prevent the aggregation of the prion protein, scrapie protein. So you would say, well, they should work. And to date, none of these studies seem to be terribly effective.
So can the MRI be normal?
Can the MRI be normal? Yes.
So that's
very early on, it's commonly normal.
So how long does it take for the changes to appear?
That I can't answer. I mean, they eventually occur. But I think very early on, you might not see much of anything.
And what's the longest survival?
I don't know the answer to that, but I imagine people could last for years. I mean, I'm sure there are people that are around for 3 to 5 years.
Mm-hmm. Okay.
I think you got to let him go now.
Yeah, yeah.
All right, guys. It was fun.
Thank you. It was a fantastic talk. Thank you very much.
Sure. See ya.
Thanks to your audience.
Take care.
Yes. Bye-bye.
Bye.
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 Thank you, both of you. Thank you.
Yeah. Thanks. Bye. And
really nice to see you after so long.
Bye.
Bye, sir.